Welcome, and thank you for joining us today for the webinar on geriatric assessment in oncology, yesterday, today, and tomorrow. My name is Jennifer Schaefer, and I will be your WebEx host. Before we get started, I'd like to make a few comments. All lines have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation in the chat or Q&A panel and select host from the dropdown. We will have a moderator ask them on your behalf during the Q&A portion of the webinar. If you do not see the chat or Q&A panel, please use the navigation panel found in the lower portion of your screen. If you need live closed captioning, please refer to the link that will appear shortly in the chat panel. Please also note that today's webinar is being recorded. And now I'd like to turn it over to Paige Green.
Good afternoon, everyone, and welcome to the National Cancer Institute's Perspective on Cancer and Aging webinar series. We host this webinar to honor Arti Hurria's pioneering and impactful leadership of geriatric oncology, and to highlight her legacy as an impassioned clinician, researcher, and mentor. It's really our privilege to share our broad interest in cancer and aging that was largely championed by Arti. Given her role as a mentor, researcher, and clinician, each webinar in this series showcases complementary research or clinical perspectives by scientific influencers at the tenured and junior academic and clinical levels. And today, we are pleased to feature Dr. Hyman Muss and Grant Williams. Dr. Muss has devoted his career to breast cancer research with major interest in treating both early and late stages, his interest in treatment outcomes, and optimizing care for older women with breast cancer. He's also had a major interest in biomarkers of aging and how they might serve as surrogate markers for the prediction of outcomes, including toxicity and survival. His servant leadership has benefited the American Board of Internal Medicine and the Alliance for Clinical Trials in Oncology. Dr. Muss is recognized as a committed mentor. He and Dr. Jan Busby-Whitehead, Chief of Geriatrics at UNC, co-chair a training grant in geriatric oncology. Dr. Grant Williams, his research bridges the fields of geriatrics and oncology and is focused on defining treatment selection and improving the outcomes of older adults with cancer. He uses the geriatric assessment approach and novel biomarkers such as molecular markers of aging and body composition to better evaluate functional age, and he develops clinical trials to improve treatment tolerance and the outcomes of older adults undergoing cancer treatment. His research also explores the pro-aging impact of cancer and its treatments in adults with cancer. And I believe Dr. Williams will be our first presenter. Thank you.
Well, thank you so much for the wonderful introduction. And it's my great privilege and honor today to talk in this wonderful series honoring Arti Hurria. So I appreciate the opportunity to be here. So as was already stated, today we'll be talking about geriatric assessment, past, present, and future. So starting with a little bit of background, cancer is predominantly a disease of aging. As you can see here, looking at the most recent SEER data, it's not until the 5th, 6th, and 7th decade of life that we start to see a significant increase in cancer incidence rates, peaking in the 8th decade of life. Already today, the median age of a cancer diagnosis is 67, and thus the majority of new cancer diagnosis occurs in those over the age of 65, and the vast majority of cancer deaths. Given changing demographics in the United States and abroad, it's actually estimated that 70% of all new cancer diagnoses will be in those over the age of 65 by 2030. So you may ask yourself, why does this matter? Why does it matter that the majority of cancer diagnoses occur in older adults? Well, unlike the developmental process that's linear and predictable, the aging process is very heterogeneous. Based on environmental, lifestyle, and genetics, the pace of aging is unique to the individual. Now, we may not notice these differences in the aging process in those in their 2nd, 3rd, or 4th decade of life, But as we get into the 5th, 6th, and 7th and beyond, we start to see significant differences in the aging process between individuals of the same age. Taking, for example, this patient, we may have some 80-year-olds that remain completely functionally independent, have no comorbid conditions, take no regular medications, that may even be able to go water skiing on the weekends, where we have other individuals of the exact same chronological age that have severe functional impairments, multiple medical problems, take a whole slew and long list of medications on a daily basis. Now, I would say if every patient that came into our clinic fit neatly into these two categories, we really wouldn't be talking about this today, and it would be rather simple. But really, this represents the ends of a spectrum of this cancer, this aging process. And it's really all these patients in between where this becomes very challenging. What is known is that chronological age in and of itself is insufficient in really distinguishing these differences in the aging process. Using these two patients for an example, we know when older adults are diagnosed and undergo cancer treatments, their outcomes are highly variable. We do know that some older adults can actually undergo aggressive and similar treatments to the younger counterparts and have similar good outcomes. Whereas at the same time, we can have some patients that are at risk for poor tolerability of chemotherapy, high risk for surgical complications, and poorly tolerate radiation therapy. So how do we distinguish who's going to have better outcomes and who may benefit from treatment versus who may be at higher risk? It's well recognized that the patient and their health status at the time of a cancer diagnosis is critical in understanding who may benefit versus who's at risk for these outcomes. And it's around assessing these older adults or assessing the aging process that is so critical in making these decisions. So how do we assess older adults with cancer? Well, this is really the clinical conundrum. It really varies across the United States and really varies by individual practitioners. We know that chronological age and performance status, which is actually a crude measure of function that's existed since the 70s, in and of itself is very insufficient, and that really it's our job to develop better ways to assess older adults. Now, I feel like we really weren't able to really glimpse how older adults were assessed until just recently. Thankfully, as part of an ASCO Older Adults Task Force, we actually did a very large survey of oncology providers across the globe. This was an initiative obviously led by ASCO, but chaired by William Dale, also include myself, Heidi Kleppen, Amy McKenzie, Enrique Soto, and Ron Majori and ASCO staff. And we really did a survey of oncology providers to get a little better understanding of how patients are being assessed. And a little bit later, I'll talk to you about how geriatric assessment is utilized in practice. But one of the questions we asked was, do you assess older patients different than your younger patients? And thankfully, the majority of respondents did. They recognized the need, the unique challenges in this population, and over half of, or 60% of participants said most or always they assess patients differently, and only less than 10% said they never or rarely assess these patients differently. Now that begs the question of, well, what kind of assessment or how are they differently assessing these patients? And the majority of these, almost 70%, is an informal assessment, whereas only 30% is a more formal assessment. And I actually like to use Dr. Muss, this is the eyeball test that 70% of these patients are doing. And I think, it's walking through the door, kind of getting a sense of how they're doing, obviously filled in a little bit by the history and physical, but it's a very subjective, informal evaluation that the majority of these older patients are getting. Now, why is that important? I think understanding this concept of the geriatric oncology iceberg is very important. So as part of our routine oncology training, we're very well adept at understanding the need to assess the cancer itself through cancer staging, through a biopsy, and then we often do a molecular test, whether it's KRAS, BRAF, macrosatellite instability, all these things that are a very important core piece of our training, and obviously are critically important into understanding not only the cancer, but what therapies make sense. In addition to that, we always check organ function, at least via baseline labs, such as checking renal function, hepatic function, and all those things that are well recognized to also be important in patients undergoing treatment. In addition to that, people do often include age as well as performance status in this assessment. Now, I would say in older adults, these things are important, But additionally, that's really only the tip of the iceberg, and it's all these things underneath that are as important or even more important often. That includes polypharmacy, comorbidity, falls, psychosocial dysfunction, functional deficits, cognitive impairment, and nutritional deficits, sarcopenia, and social support. And really, in a lot of these patients, we're just assessing the tip of the iceberg, and we really need to be doing these comprehensive assessments to truly understand everything that's going on in these individuals in order to make personalized treatment plans. And that's what really brings us to this concept of the geriatric assessment. So first off, what is a geriatric assessment? It's a multidimensional, interdisciplinary diagnostic process that focuses on determining an older person's medical, psychosocial, and functional capabilities. As you can see here in the figure, this is really a multi-domain, comprehensive assessment of the health status, with particular focus on age-related changes. So we're talking about all those things underneath the iceberg that are underwater. So cognition, comorbidity, the presence of geriatric syndromes, nutrition. And I think it's important to realize that this involves not only an evaluation aspect, but also a management side to this as well. And we'll talk about that a little bit more as this presentation goes along. What are the challenges in doing a geriatric assessment? This often requires specialized personnel, time, and expertise. So I actually did a geriatrics fellowship at UNC, and typically these patients would be slotted for a 2-hour evaluation in the clinic. They would see the geriatrician as well as a pharmacist that has specific training in aging, as well as a physical therapist and a social worker, and then we would all get together, meet, come up with a comprehensive plan that included not only this evaluation, but management side. And frankly, I think it was wonderful, but I think we can all recognize the challenges inherent with that, because we're not talking about a small number of individuals that this would be relevant to. So what really is the availability of geriatric specialty care? Can we really involve geriatrics in seeing the majority of these patients and really partner with them in this? I actually had the opportunity to work with the NCI NCORE Research Network, particularly the Wake Forest Research Base, in collaboration with Heidi Kleppen and many of those at Wake Forest. And as part of this landscape survey, they actually surveyed all of the practices within the NCORE Research Network. Now, this was really for two purposes. One was to understand what kind of research was really feasible across this network. They don't want people proposing research studies involving nutritionists or geriatrics specialties if they don't have access to these specialties across this network. But at the same time, this is actually a very big population of trials that are mostly networks of clinics across the country, and I think are more representative of what's actually available within community oncology clinics and not necessarily those in academic centers. So it really offered us a glimpse into what's available within community oncology centers. And you can see here we had about 50% that completed the survey, which represented 210 oncology practice groups and over 500 community oncology practices. The majority of these were in the West and the South, but also had some representation from the Midwest and Northeast. Now we asked them, what was the availability of geriatric oncology providers? So these are duly trained geriatric oncologists, and only 2% of clinics had an available geriatric oncologist. So I think there's absolutely no way we're going to be having all these patients be seeing a duly trained specialist in this area. But more importantly, we looked at what is the availability of geriatricians for consultation or co-management at the sites. And a third of these community sites said that they had an availability of a geriatrician to them. Now we broke this down further as where were they able to have this? And actually the majority of these were actually in the inpatient setting, with a smaller number, only 13% that had available within the oncology clinic. And most of these were available external to the oncology practice. So when we worked that out, about 5% of these community oncology centers had an available geriatrician for consultation or co-management in the oncology clinic. So when I think we're thinking about models of care that would be particularly scalable across the United States, I think it's pretty clear that although for some patients partnering with geriatricians would be the right thing to do, I think we need to develop models that are scalable, that does not necessarily going to involve a geriatrician seeing all of these patients. Now, I also like to think of it kind of in a glass half full sort of way also. And another thing we did in this manuscript was actually look at the availability of a lot of these other very critical specialties that are very pertinent to managing older adults. And thankfully, a lot of these were widely available. So 84% had social work, 81% nurse navigators, 3/4 had pharmacists, also high levels of dietitians and rehab and caregiver services. So we all recognize this as a multi-disciplinary approach to these patients. And thankfully, although the geriatricians may not be widely available, a lot of the critical multidisciplinary members are available. Now, this is not, although this is new data, this is not entirely new concept. And this really brings us back to Dr. Hurria and really her pioneering work in this field. And really was when she was still a fellow that it was becoming very widely recognized that we needed to do something other than having a geriatrician do these full comprehensive assessments if we're really going to be able to make inroads into geriatric oncology. And at that point, she really took this very domain-based approach to the assessments and tried to find a lot of patient-reported or very simple validated measures to really hit all of these individual domains. And you can see here from her publication in 2005 in Cancer, where she really developed this cancer-specific geriatric assessment. And looking at this a different way, what was also critically important is only a few of these measures were done by the health professional or the clinic-based team, which include the timed up and go, the performance status, and the blast orientation memory concentration. But the majority of this, the bulk of this really came down to patient-reported measures of function, falls, medications, comorbidity, and mental health. So she took what was that, perhaps 1 to 2 hour evaluation and really distilled this down to only 5 minutes of the health professional provider time and 20 to 25 minutes of patient-reported of the patient's time. So this is about 25 to 30-minute assessment. And this really moved, it seems very simple now, but really moved the field forward where we can finally assess all these domains and really improves not only our assessment and what we're able to do in the clinic, but also our knowledge base around the prevalence of falls and all of these other really important domains of health. Now, I like to borrow this term, staging the aging, and I have to give credit to William Dale on this, who really came up with this idea, which I think is great. We all talk about staging cancer and we learn about that, but just as important is staging the aging. And now this is an oversimplification, I'll admit, but I think it's important to realize, how can a geriatric assessment, how do we use this? What is this going to look like in practice? And a very simplistic way of viewing this is it can find some individuals that are fit. So these older adults have no functional impairments, no significant comorbidities, and no geriatric symptoms present. And frankly, I think these are the patients that may not warrant undergoing any further evaluation in that sense. And really, they are able to go ahead and get aggressive treatment or to go have surgery or to really be treated like their younger counterparts. On the flip side to that, we can find these frail individuals that may have dependence in activities of daily living, 3 or more, or at least one life-threatening comorbidity, and potentially have the presence of clinically significant geriatric syndromes. And I think we recognize these are the very high-risk older adults that may, frankly, not benefit from cancer treatments, or if they do, they need to be really modified and adapted to this specific population. And definitely supportive care and measures would be very important and critical to this group. But also, it's really this in-between or vulnerable group where I think a lot of the biggest challenges lie. Some of these are patients that wouldn't be recognized as vulnerable at all and often thought as being fit or perhaps incorrectly identified as frail, but they would often have dependencies in IADLs, but not in activities of daily living. They would have some comorbid conditions, but nothing that are severe or life-threatening, and typically don't have these geriatric syndromes other than maybe mild depression or mild memory disorder. And so this is kind of a very simple way of viewing the geriatric assessment and how these results can be important in practice and in personalizing these treatments. So what is really the value of geriatric assessment in oncology? Now, this is an ever-changing thing, which is a wonderful problem for us to have in the field, and Dr. Muss will be talking a little bit more about that. But in a very forest view is that geriatric assessment clearly uncovers problems not routinely found. And a lot of the early work, once we started implementing geriatric assessment, was showing how there's all these undiagnosed things that we're really missing as part of our routine assessments. It allows for a more accurate life expectancy estimates, which I think Dr. Muss will also talk a little bit more about. But this is particularly critical in the adjuvant treatment decision making, where some of the benefits we're talking about may not happen except for 5 to 10 years or further down the line, and really understanding competing risk of mortality is critically important. Some of the seminal work by Dr. Hurria as well as Dr. Eksterman is looking at how it can predict treatment-related toxicities, and more recently been looking at hospitalization, nursing home placements, surgical complications, so a whole host of things it can predict. And more recently, we've seen that it can improve communication, particularly around aging-related conditions. Dr. Mohili recently published within the last year some seminal work focusing on this. And we've known for decades, thanks to a lot of pioneers in geriatrics, that there are a lot of beneficial interventions that can help improve function, potentially reduce chemotherapy toxicities, quality of life, and survival. And this slide's a little bit dated here, and I'm going to let Dr. Muss talk a little bit more about the very exciting recent contributions to the field that really focus on this and some of the exciting work that's really going on. But I really want to hone this down when we talk about what are interventions that we're going to do based on geriatric assessment. And I think it's important to kind of separate these out into two different aspects. So one is very unique to the older adult with cancer, and that this can actually change and modify our cancer treatments. Often, depending on the situation, I'm a GI oncologist. I treat a lot of pancreatic and colorectal cancer. We can be talking about 3 drug regimens, such as something as aggressive as FOLFIRINOX versus single agent capecitabine. There's a whole host and a wide spectrum of treatment options we have. And I think understanding the fitness of the functional aging of the individual can be very helpful to kind of tailoring that treatment. As well as can really modify the supportive care related directly to the cancer treatment, as well as obviously the adjuvant setting, do you treat or do you not treat, and all of those sorts of things. So I think it's important from an intervention and modification of the cancer treatment, but separate from that, there's interventions more based on general geriatrics. So this would be, assessing falls, for instance. We know there are evidence-based falls interventions that have been shown to have proven benefits. And I think really focusing those interventions on the older adult with cancer, and there's more work going on how that could or should be tailored to the older adult, but I think these are 2 different ways. These are kind of more general geriatric interventions as well as cancer or oncology specific modifications. And here's just some examples of what some of these interventions can look like based on these impairments. So I think this sounds great. I'm sure everyone's drank the Kool-Aid and that we're all doing this. I'm sure every patient in the U.S. is undergoing a geriatric assessment. In reality, I think that's not quite the case. And going back again to this ASCO Older Adults Task Force, we actually asked people that completed the survey, how often are they performing a geriatric assessment? And I think here things were a little bit less optimistic, in that over half never or rarely performed a geriatric assessment. And it was really only 20% that most of the time were always performing a geriatric assessment in the management of older adults. So, looking forward to the next steps, I think we have growing and more evidence that there's benefits to using geriatric assessment. This survey followed up and asked, what are the perceived barriers to using a geriatric assessment in clinical care? And I think here really highlights some of the areas that are of greatest concern. And a lot of this is people's lack of awareness of tools or uncertainty of which ones to use. They have a lack of training or a lack of support staff, and frankly, an overall lack of time. Now, again, being a little more on the optimistic side, I think the nice thing is to see, even before we had some of these great seminal recent presentations in ASCO, only about a quarter of individuals felt that there was limited evidence to support its use. And I think this gets back to the idea that this is really, it's so intuitively recognized that these patients should be assessed differently. And I think we're seeing agreement that they're trying to assess these patients differently, but I think that they don't really understand how to do this geriatric assessment and how that can really be used in practice. Now, this is actually data that has not been actually published yet and is in press at JCO Oncology Practice, and hopefully be released in less than a month. So I'll stop there, and I just want to acknowledge, all my mentors, co-investigators, and collaborators, both at UNC and at UAB, with a special thanks to Dr. Smith Abatia and Hyman Muss, really my mentors for this. And as you know, it takes a village to get in and do research like this, and also to thank funders, National Cancer Institute and American Cancer Society. And I will hand it over to Dr. Muss.
I need to unmute myself. Good afternoon, everybody. Again, I thank the organizers here. It's a privilege to speak at this webinar, which recognizes really one of the finest human beings, as well as one of the most outstanding scientists and mentors for all of us, Dr. Arti Hurria. So I thank the NCI and all my colleagues for arranging this. And it was great to see Grant give that wonderful discussion. He's a leader in this field, and I'm pleased to say he began a lot of this at UNC. So, for some reason, I am hitting the page down, but...
Dr. Muss, you'll just have to use your mouse to click somewhere within the...
Oh, I got it. I got it. Thank you.
Yep, no worries.
Yeah. So how do we put the geriatric assessment into action? Key question. I'm going to show you some practical tools during this talk to help you. One, about life expectancy. Frequently, and because we have a continuing age bias in the United States, when we hear someone is 75, 76, 80, we think they're a very old person and they're not going to be with us for a while, but we're very frequently wrong. The other thing is I'm going to show you an index we built from the geriatric assessment that really is related to mortality. Terms like frailty are widely used, but what do they really mean as far as how a patient does through their trajectory of cancer? The other thing I'm going to show you some chemotherapy toxicity scores. The CRASH score, I'm not going to go in detail, developed by Dr. Exterman, but I'll show you the website. And the CARD scores developed by Dr. Hurria and our colleagues. I'm going to show you what I think are 4 seminal abstracts that really show how the GA can really help in decision-making. And these were all randomized trials, level 1 evidence, that were presented at ASCO this year. And then, can I get support for this? I know in Grant's discussion, he showed that limited support was only a small percentage, but when you really look, a lot of people were unaware of the tools, and I think that it takes time to do this and record it. And if we can't get supported in an age of medical care, we're asked to do much more with less resources, that it really won't come to pass. And then lastly, a few future directions. So I think Grant showed you the difference between these two women, Katharine Graham on the right, a newspaper empire, and the woman on the left, sick, frail, in assisted living, both 75. Well, if you visually saw them, you would think much differently about them. But if you just saw the age alone, you might be more biased to the woman on the right who's sick. And that might be a bad decision maker in clinical practice. So what you really want to know is the patient's life expectancy. And there's a wonderful tool on the web, ePrognosis. It's been supported by lots of federal funding and looked at community dwelling adults, people in nursing homes. I advise you to go on the website, and there are multiple calculators. And I took one here where I'm going to show you to estimate the patient's life expectancy without cancer. So when Grant sees his patient in the clinic with colorectal cancer, what he really wants to know is how that patient would do in their life. How long would they live without the colorectal cancer, so he can recommend appropriate therapy. And I will show you how this is done. So this is one of the scales, the Lee Index. It's 10-year mortality. And I picked a patient who is relatively healthy, but she's older, 75 to 79. She has a normal BMI, no history of other cancer, no diabetes, COPD, hospitalizations in the last year. And I point out that there are several questions here from the geriatric assessment. So if you didn't have time to do the geriatric assessment, you could at least look at these questions, and you could see hospitalizations in last year. Well, frequently that's not a question we ask a lot of older people in the clinic, but it's key. It's key data. Self-related health. 2 people, identical cancer diagnosis and comorbidities. One tells you, doctor, my health is really good, and the other, oh, not so good, fair. The person who told you it was fair will not survive as long as the other patient. A simple question. And then dependence and activities of daily living. If a patient cannot dress or wash themselves, they're really going to be quite unable to tolerate most modern therapies. But instrumental activities of daily living are important too. Can they use the telephone? If they get treated, can they call the nurse or physician about side effects if they have them? Key things. And then difficulty pushing or pulling objects just in the scale, and it's a simple question to ask. So if you look at this patient here, you see that her 10-year mortality is 15 to 23%. I suspect that most of you didn't think it was this good. And her median survival is 17.7 to 21 years. So this is really probably exceeds your guess. And your guess, and my guess too, is based on some bias. So this is very, very important to estimate with the available data at hand. Now, we took information from the geriatric assessment at UNC several years ago when we built the frailty index. And we took the geriatric assessment, and I'm not going to dwell on this in the interest of time, but we picked a series of questions. We used a technique developed by Dr. Rockwood and colleagues, where we pick certain domains like physical function, cognitive function, and get a representative sample of questions from each of the domain. For instance, can you use a telephone? Some without help, and gave it a simple score. And from 36 questions, we were able to develop a score, and the score is a little complicated, but essentially it's between 0 and 1. And if you got a score close to 0, you were in great shape. And if you started getting close to 1, you were not. And we built a frailty index, and the frailty index divided patients into 3 groups, somewhat arbitrary, but you can easily see how the math is done. And then subsequently, we were able to link this with the help of our colleagues to the National Death Index and show that even the simple group of questions in a very wide variety of patients with cancer, some with a new diagnosis and others with an older diagnosis, that it was highly possible to predict their survival. So this frailty index defines frailty as a characteristic related to survival and can help in your decision making. The other is toxicity. So this is a nice patient who said that if your time hasn't come yet, not even a doctor can kill you. So I apologize to those on the call who think that this may be crude, but unfortunately, we have a lot of treatments that can probably do this, and we've got to be very, very careful in decision making. So to try to get some data that could help in decisions, Dr. Hurria again pioneered a CAR toxicity calculator. And in this calculator, she calculated the risks for grade 3 to 5 toxicity in older patients with cancer. Some of them had curable cancer, some did not. Some had metastatic cancer, some did not, but it was 500 patients, and she developed a score from the odds ratios of many of the questions in the geriatric assessment. And you can see in this model, falls came in the model, hearing impairment, limited walking, assistance with medications, and decreased social activity. And so this score was very, very helpful and could help you define grade 3 to 5 toxicity. Now, grade 3 to 5 toxicity can be very substantial: severe nausea and vomiting, mucositis, very low blood counts, risk for infection. So this was very important. And hypothetically, I took a patient and I gave them 7 points. So a 75-year-old woman, perhaps with breast cancer, and she's going to get standard dose chemotherapy. That's your plan. And in breast cancer, virtually all the chemotherapy we give in the preventive setting consists of several drugs, what's called polychemotherapy. So she has 7 points. And so when we look at what that means, it means she's got about a 50% chance of getting severe toxicity. And that's important to discuss with her and go over what these might be with the regimens. If we look at performance status, which is a very crude measure of function that Dr. Williams mentioned in his earlier discussion, you can see that it was virtually worthless in predicting serious toxicity. So this score gave us a very good idea of how to discuss with a patient potential side effects of treatment. This has been expanded And there's a lovely study, again, pioneered by Dr. Hurria, presented by Dr. Magnuson, that has now being reviewed by one of the major medical journals, looking at this same toxicity score in 500 women with early breast cancer, all 65 and older. So this was an R01 done by Dr. Hurria, again, and led by Dr. Hurria. It included patients from all over the country. And there were 473 patients 65 and older in the final data set. They all had standard of care currently used adjuvant chemotherapy regimens. And I've showed you on the other slide predicting the grade 3 to 5 toxicity. And in this data set, we were a little bit better because they were all breast cancer patients. They were all early stage, and they were all women who were going to get standard of care treatment. But you can see that the scoring allowed us to predict dose delays, dose reductions, hospitalizations, and you can see the substantial differences in hospitalization rates between having a high and low score, and RDI, which is relative dose intensity. So in many areas of cancer care with chemotherapy and drug therapy, getting enough of a dose into the patient without lowering it substantial is important, especially in early breast cancer. And they showed that it was a predictive of that as well. So I think that these are the types of studies that are making the geriatric assessment of really practical value. And we need more of these studies, and people are doing them in colorectal cancer, in leukemias, in other commonly used solid tumors, lymphomas, myeloma in patients, so that when we see patients, we can really use these data to help them make the best decision, because treatment decisions in older patients are always shared with the patient and frequently with their family. This cancer in virtually all people involves the family, but in older patients, it's usually crucial that everybody is on the same page in the decision making. Now at ASCO this year, there were some wonderful presentations, and there were 4 randomized trials. And I urge you, and for those interested, I can supply information on how to get to them in the ASCO website. But these were 4 randomized trials, all of them comparing some form of GA, geriatric assessment intervention, with standard usual care. And usual care usually doesn't mean a lot, by the way. As Grant showed you from his wonderful review of what people are actually doing out in the community, and it's the same in major academic medical centers. We all have the same issues. We frequently don't have enough manpower or time to really get into the weeds and provide the appropriate interventions. But this study did it. And there are 4 of them. I'm going to actually concentrate on the GAP70 study by Dr. Mohili and her colleagues. There is a surgical study at the bottom by Dr. Kian, which is very interesting, looked at interventions versus usual care in GI cancer. There's a very wonderful study from Australia by Sue and colleagues, Integrate. It's a hard word for me to say, but it's a very clever way of putting the geriatric assessment into patients' care. And then a study by Lee et al., the GAIN study, led by investigators at the City of Hope, which is really a spin-off of Arti Hurria's work as well. So in Dr. Mohili's trial, she randomized patients to the geriatric assessment of usual care, and the endpoints in this study were clinician-related grade 3 to 5 toxicity, survival at 6 months, and treatment decisions. How were treatment decisions made, such as dose reductions, et cetera? And she also measured functional and physical decline in patient-reported toxicities. And this is really a wonderful study because it was done out in the community with NCORE members, and it's a tribute to the NCORE team at the NCI for putting this together and funding this. It was also done on people who had serious cancers. These were patients who did not have potentially curable cancers for the most part, but they had advanced cancers. So these are people where side effects from treatment in a situation where you're not going to be able to cure the patient can be overwhelmingly bad in the quality of life, because there's not going to be much of a gain out of it as far as long-term outcomes. And you can see she looked at several domains. This is very similar to the slide Dr. Williams showed you in his talk. She measured objective physical performance, psychological status, and nutrition. And this was really, really very well done. And then she had very well-defined interventions that were available for the study team. And what was neat, this was a study done in a cluster randomization. So she was able to have some hospitals that actually were very deep into the GA and did all the interventions, and others that didn't. Because if Grant was down the hall from me and we were both seeing a patient, and I asked him about the patient, he would say, you need to do these interventions. And so there wasn't any type of confounding by having investigators change how they manage patients during the study. Extremely well done type of intervention. And you can see here one of the primary endpoints, grade 3 to 5 toxicities at 3 months, that you can see for any toxicity, it was about 20% higher in those who got usual care. Because in the GA, they made certain dose modifications, et cetera, to limit the toxicities, and that apparently worked. Hematologic toxicity was different, not quite as much different, and frequently hematologic toxicity, like lowering your white count and things, don't really have a profound effect on the patient's performance, unlike anemia can or low platelets can. So this toxicity is very important, but what's more important is non-hematologic toxicity, because grade 3 to 5 toxicity is fatigue that puts you in bed. It's nausea and vomiting that prevent you from eating for several days and can lead to dehydration and hospitalization. It's bad mucositis, diarrhea. These are really key major toxicities. And you can see that the assessment allowed the clinician who used it to reduce toxicity by about 20%. That is very, very important in a group of patients whose goal of treatment is to maintain the best quality of life because they have incurable cancers. Now, treatment intensity was a little less in usual care, and we're going to get to that. And that's important. Dose modifications were a little less in the GA intervention. One of the reasons probably because they made some modifications from the get-go. The question all of us were asking before this study was, well, of course we can lower the risk of side effects in patients by lowering their chemotherapy doses or extending them out. That's just common sense. But the real question is, if we do that, do we compromise the benefits of treatment, right? If I lower your dose, am I going to shorten your survival? You may have less side effects, but what if I shorten your survival 3 to 6 months? That would be something that you might find, well, I'm going to tolerate the higher doses of treatment and risk the toxicity because that's very important. So when you dose reduce, you'll get less toxicity, but you've got to make sure that your treatment isn't being affected to compromise the patient. And that's where I think that this study is unique. And the other studies are going to do this too, because they looked at survival estimates at 6 months in these patients. And many of these patients are not going to survive for 6 months. As you've seen here, about 70% hadn't survived at 6 months. And these patients had to be at least physically able and cognitively able to participate and perform this consent issues and realize what this study was about. And if you could see, there's really no convincing evidence. The p-values are really non-significant of any really harm to these patients at 6 months based on the Kaplan-Meier estimates. And there's a numerical value difference of about 3%, but it's well within the confidence levels here. So I think this is really encouraging that we can pick a group of patients, we cannot cure them, they quality of life and spending time with family and not being a burden to their family are their major goals. And we can tell them that if we can do the assessment and then we can recommend some of these interventions, as was recommended in the study, and very precisely defined and probably amenable to most of us, whether in a community practice or an academic setting, that we can not compromise their outcomes, but make our treatments less toxic and maintain or possibly improve their quality of life. Okay, So I've always debated whether to put this slide in, but I've done it because one of the real issues is, as Grant and I will tell you, our friends have heard us speak several times about this. They believe us. They know the data, maybe not as quietly at their fingertips as Grant and I, but they kind of get it. And I am sure that all the participants on this call kind of get it. But the question is, how do we do it? How do we take a busy office practice, a busy academic practice, and now adding the COVID issues on it and do a geriatric assessment? How do we do it? Well, I think being able to reimburse it is a crucial issue because unless physicians and other healthcare providers, whether they be nurses, social, can get reimbursed for taking the time to do this. Don't forget, the assessment may only take 20 or 30 minutes, but it takes time to refer people to physical therapy, to social services, to let the patient know about the appointment, all the little things that gets to be so complicated, especially with older people, that there's got to be a way to put money in the system for people who do this. Well, one thing that can be done is these short screening tests, G8, 8 questions on older people. It's got a reasonable sensitivity and specificity. And for those interested, you can do a screening test of a patient very quickly. If they can answer some of the questions about their healthcare insurance in this country, they can do the GA test. And if they're really very healthy, maybe you can skip the GA on that patient if you're time limited or resource limited. But if you're not, there are reimbursements. And I put here, for those of you who might be physicians or nurse practitioners or PAs who can use these codes, or any of you who work in the healthcare system, to mention it to people who use these healthcare codes, that if you document a visit with a patient for more than 30 minutes and you do that assessment, and don't forget they have to sit there, even if it's self-administered, and fill it in on some tablet or on paper or whatever, and you have to look at it. If you can set that up, you are able to get reimbursed for this. And I think this is very, very important. And I've worked this out with our billing people at UNC who are ultra conservative. So if you're interested in this, you talk with your billing people. I don't want to get you in trouble, but it does provide you a venue for setting this up in the clinic and doing it. Because I think Grant's slide is very telling. And I think a lot of that is people just don't have the ability to set it up and make it work for them. There are several outstanding websites available that I think complement this talk, and also a lot of the other presentations as part of this webinar series, which were some of them, all of them virtually have been outstanding. One is ePrognosis, can be used by virtually any professional. Very simple questions, and it also actually has a calculator for people at the end of life. So although it's not a part of our discussion today, it really is very, very helpful, because we know that many caregivers, especially if the patients are their friends, overestimate their life expectancy near the end of life. MyCarg is a wonderful website. It's being redone, and Grant and many others have worked diligently to get up all the tools. So if you're interested in some of this research or just want to use it in whatever way you want, maybe to care for your own family, you'll be able to go on this website and use the tools. And right now you can go on it, perform the geriatric assessment, get all the domains scored, and learn a lot. It's a terrific website. The CRASH score is from Moffitt. It allows you to calculate chemotherapy toxicity. It's a little bit different than the CARG score, which I showed you, by Dr. Hurria, but it's extremely good. And by the way, the CARG toxicity score is on the MyCarg website. Predict UK is a great thing for breast cancer patients to predict the benefits of treatment. And it has data reasonably good on 80-year-olds. So it's something to think about if you're in that area. The International Society of Geriatric Oncology, a lot of good tools. CancerNet, ASCO. And for those really interested in geriatrics, there is a wonderful site with video clips and educational materials. And I suspect that a lot of people on the webinar today, that this may be a very generic audience made up of a lot of different kinds of professionals. You might really enjoy this website because it has information on all types of care of older patients, not specifically cancer. So I think that that's a wonderful thing for many of you to explore. So where are we going? Well, in the future, we need to more forcibly integrate geriatrics training into medical school and residency programs. Geriatricians are like pediatricians. We're kind of soft people, you know, we don't want to be too pushy. But if we want to get this going, we've got to push for our place in curriculum. This is an aging population. And I think it's just as important to spend a few weeks learning about caring for older people as the gene of the day, which may only be appropriate for treatment in a very small % of patients. And so this is something we really need to push for. And many of us are trying this. There's a lot of pushback. Everybody wants a piece of medical education, but it's something we really need to do. And it's especially important in residency. And in oncology residencies, whether it be GYN oncology or medical oncology, to integrate geriatrics training into these programs. The other thing is we need to improve and provide motivation of our current specialists to use the GA. Well, I think they're probably tired of talks by myself, and Grant's expertise is exploding, and they're probably going to get tired of him too soon. But we really need to push, and we really need to, I think, bring this into office practice now. We need to set up little teams that we can physically work with people on a Zoom meeting and teach them how to do this in their office and make it really practical for their patients. And I think the time has come. And then I thank the NCI and the NIA, but the NCI, and we've got Ned Sharpless as our wonderful director. And as many of you know, Ned is one of the world's experts on the biology of aging. And he's an amazing guy, and the NCI has put out some RFAs and getting interested in this. And we've got to increase the pool of funding to learn about predictive models, to learn about new genes, to learn about the fundamental biology of aging and what are interventions that can at least stabilize people who are reasonably good shape, and maybe, if we're very lucky in the future, reverse some of the really adverse effects that come with aging. And then I'd like to thank our NCI and NIA friends. I speak for Grant and myself. We really appreciate all the work of Jennifer, Amy, Alicia, who fixed my slides. Thank you so much. And Lisa and Paige Green for really setting up these wonderful series of webinars. They really take a lot of planning, and in working with old people like me to get these slides right, it's really very special. So thank you so much. And then just to end with Arti, I love this quote. She used it all the time, and she lived by it. We see a lot of slogans, especially this month. But this is a way Arti Hurria lived. And if you want to go fast, go alone. But if you want to go far, get together. And that's why we're having this webinar today, because she lived this. She taught us all. She was inclusive. She was elegant. She was intellectually amazing. And we all loved her dearly, and we mourn her loss. And thank you. And then this is my great team. And you can see Grant here when he was a relatively young guy, and some of the wonderful people that Grant and I and many others have had the opportunity to work with. Thank you very much.
Okay, this is Lisa Galicchio, and I'm going to moderate a couple minutes of Q&A. So if you have any questions for Dr. Williams or Dr. Muss, please enter them into the chat box. So the first one, I'm going to direct her towards Dr. Muss. Given the explosion of telemedicine during COVID, can you comment on whether a geriatric assessment can be done or should be done virtually?
That's a great question. And I think over the years, there are papers, for instance, showing that things like the up and go test, gait speed, can be done virtually over the web with some visual platform. And I think actually COVID and the video medicine we have now, it's lending itself to do this. It's not as nice as seeing a patient face-to-face. One thing we learned from Arti, you learn an awful lot watching a patient get undressed and getting on the examining table in a clinic. It's a great measure of their physical health, and you can't do that well. But a lot can be done at home, and I think we'll be able to do this at home. And I know that, I think I speak for Grant and myself, when we've moved some of our research here into the video platform. So the answer is yes. I believe we can do it. In fact, maybe we can do more of it with this. Face-to-face is lovely, but I think we can take advantage of a positive out of COVID and really expand the use of GA with video.
And I guess that also goes back to the need for more training, not only in the clinic, but then virtually.
Yes.
So.
Yeah, yes. And I should add that GA takes only 10, 15 minutes in a healthy person. But the people that are vulnerable or frail, they take a lot more time frequently and help in doing this. So training, sensitivity, patience, learning about different cultures and cultural groups and how they approach issues like this is all important.
So I'll direct the next question to Dr. Williams. Are there any laboratory tests, for example, the neutrophil to lymphocyte ratio, that would be useful to assess in this geriatric population?
So I think that's a great question, and in the area of ongoing interest, I think, you know, the answer is yes and sort of no. So none of these that have really entered the clinical realm yet to date, but I think there's a lot of promising and interest in biomarkers of aging. You know, is there a central lab test that we could do that could help us get at what a lot of this geriatric assessment's also really getting at? The nice thing about the neutrophil lymphocyte ratio, which has been shown to be associated with frailty and a marker of overall prognosis, is that this is routinely, you know, obtained as part of a differential and a CBC. So almost every patient I see has one of these. So I think it can be useful, but I don't know of anyone that's actually, you know, bringing this into decision making. And then Dr. Hyman Muss himself is one of the leaders in senescence, cellular senescence, and looking at biomarkers such as P16 in particular, and looking at how that might be a potential, you know, surrogate for this aging process and understanding how that can be predictive of outcomes. I think there's been a lot of research on that going back a decade or two. I think we haven't landed on anything yet, but I think that's still a very much an area of interest.
And I'll direct this one to Dr. Williams as well. Again, this person says, thank you for the wonderful talks. Have clinician scientists looked at the need for designing geriatric assessments based on cancer types and agent types?
So again, great question. So I think, you know, we're standing on the shoulders of giants. I think Arti, Hurria, Dr. Exton, and some of these were able to develop tools such as the CAR or CRASH tools to predict chemotherapy toxicities. And some of the early work has been across disease types. I think, you know, there is some similarities across disease types, but as a clinician, you know, there are focus within specific cancers when we're thinking about, you know, do I use FOLFOX, FOLFIRI, or just 5FU alone? You know, this is a very disease-specific question to colon cancer. I think that was recognized. I mean, Dr. Muss presented Dr. Hurria's work on adjuvant breast cancer. She followed up her chemotherapy toxicity prediction to a refining that in breast cancer. I think we need to do that in colon cancer. We need to do that in pancreatic cancer. And I also think these interventions down the road would be benefited to be targeted in these populations because the outcomes are a little bit more homogeneous across these groups. So I think the short answer to that would be yes. I think we do need to tailor these to cancer types and certain agents to be really even more clinically useful and more, I think it would help other oncologists understand the data and the outcomes even more.
Well, great. So we've come to the top of the hour, so we're going to wrap up. If anybody has any burning questions that they would like answered, please reach out to our speakers individually. We have 2 webinars in this series coming up. One is next Monday at 1 Eastern Time. It's titled Hindsight is 2020, Lessons Learned from Cancer and Aging Researchers on Submitting an NIH Grant. The speakers will be Michael Irwin and Supriya Mohile. And then November 2nd, at 12 Eastern. Our speakers will be Garnett Anderson and Elizabeth Cespedes Feliciano. So we hope you can join us for those webinars. And as always, please send speaker suggestions or feedback to our email address. Once again, thank you to our presenters and to our attendees, and hope to see you at these future webinars.
Thank you.